Anesthetic considerations in hypertension. Welcome to this topic. My name is Dr. Janvi and I've done my MD along with a fellowship in neuro and regional anesthesiology. So this topic is something that I think you all will be able to teach me better than I can, because we see this all the time. Patients come to pre-op OPD, they have high blood pressures. Patient come to OT, they have uncontrolled high blood pressure. Intra-op, high blood pressure. Post-op, high blood pressure. So all of us keep trying to manage this high BP. But you know what? I'll tell you from my personal experience. Now, when I was a resident, we were taught that you have to first find out the underlying cause for that high BP. You should not just give antihypertensives to the patient, but you should find out, is it because of the uncontrolled systemic disease? Is it because he's anxious? Is it because of pain, shivering? What is the cause of the high BP? Okay. And we used to treat it accordingly. And what I learned during my formative years was, basically just increase the depth of anesthesia, give propofol bolus, increase volatile anesthetic agent for managing high blood pressure. Cut to leaving residency, joining newer places. From there, from different anesthesiologists, I learned, okay, if nothing is working out, if you're not able to find out the cause, or if it is systemic hypertension, that is the underlying cause, then in that case, we have other drugs to give. So there I started using NTG, sodium nitroprusside, esmolol, metoprolol, labetalol, all these drugs, okay. So trust me, for the first 3 to 4 years of anesthesia, I had not even used these drugs. But over a period of time, I learned how to use them. In which cases is it actually that my patient has inadequate depth of anesthesia, and in which cases is nothing working out and you need to start beta blockers. So along with how you evolve during your journey of anesthesia, you learn how to use a lot of drugs. But at the end of the day, what you learn basic during my residency, like I learned, was find the cause. Find the cause and treat it. It is not the reason. You do have drugs which will immediately take care of the situation, but at the end of the day, you will be a better anesthetist if you use a little bit of the mental capacity that you have and try to find the cause of it. Okay, so the commonest cause of case cancellation in pre-anesthetic clinic or even just right before the OT is A, if the patient has high blood pressure, and B, if the patient has abnormal potassium levels, especially hypokalemia. Patients often have hypokalemia, okay. So you all must have also cancelled a lot of cases, and I remember in our institute, the last induction time used to be 4:30. And 4:15 they used to get this patient who was not very optimized, and they used to say, chalo, now induce this patient. And we used to say, but the patient's blood pressure is high. I cannot induce patient at this high blood pressure of 180/100. So they used to say, no, anesthetist is cancelling case because it is almost 4:30 now, so they don't want to take a new case. So at that time, I used to feel like, okay, we are cancelling case, aisa to nahi hai, I can give propofol and the BP will come down. But that was not the case. Over a period of time, I realized that often when your list is getting over, the surgeons will go and get cases that, they saw just yesterday or day before yesterday and who are not very optimized. So it is a actual mix of many factors from the surgical side, patient side, as well as anesthetist side that leads to a case cancellation. What is the incidence of perioperative hypertension? So if you see, at least 10% of the patients coming to the OPD in pre-anesthesia clinic end up having a high blood pressure. So you will do your PAC clinic, your nurse will come and she'll check the blood pressure and she'll say it is very high, the BP is very high. You check it a couple of times, it tends to remain high, so the trend is high. So in males, you see this happening more often as compared to females, and it is seen that out of these 10% patients, okay, suppose I saw 100 patients in the OPD today, and out of them 10 patients had high blood pressure. Now, when I take these 10 patients in the OT, and if I have not optimized any of them, it is seen that at least 5 of them will have intra-op hypertension. Now, why am I doing this maths with you? I mean to say eventually that 50% of the patients that you don't treat or don't optimize prior to surgery will end up having intra-op hypertension. Why am I scared about intra-op hypertension? It can put a strain on my heart. It can cause cardiovascular abnormalities, ischemic heart disease. It can affect my brain. It can cause cerebral hemorrhage. It can cause stroke. It can affect my kidneys. It can cause hypertensive nephropathy. It can lead to proteinuria, kidney damage. Intra-op, it can lead to excessive bleeding, and I might have to transfuse the patient, and the surgeon is going to give me one full-on shouting, okay, ki patient's BP is so high, and I'll be struggling so much as an anesthetist because I want that my patient has an optimized hemodynamics, but the blood pressure won't come down. So why do you fall into that situation when you have the option right over here in the pre-anesthesia evaluation OPD to send the patient to the physician, start them on antihypertensives and get them optimized prior to surgery, okay? So let's have a look at what do you define hypertension as. So when we were talking about diabetes, we saw how diabetes is defined. How do you define gestational diabetes? How do you define all your different types, you know, like poor glycemic control. So impaired glucose tolerance, okay. So here we will define hypertension as per JNC8 criteria. So JNC8 criteria says that normal blood pressure, systolic is less than 120, diastolic is less than 80, okay. In case of pre-hypertension, systolic pressure is between 120 to 139 and diastolic pressure is between 80 to 89. So this patient is pre-hypertensive, okay. Now, when do I start defining them as hypertension? I start defining them as hypertension when the blood pressure crosses 140/90, okay. So that means stage 1 hypertension is when the patient's blood pressure is 140 to 159 and diastolic is between 90 to 99. Stage 2 hypertension, patient's BP is 160/100, more than that. And there is also another stage, stage 3 hypertension, in which patient's BP is more than or equal to 180 systolic and more than or equal to 110 diastolic, okay. So this is the JNC8 criteria. What do I need to remember from here? Stage 1 hypertension more than 140/90. That is the most basic thing that I need to remember. If I can't remember any of the other stages, it's fine, but this has to be remembered. What is primary hypertension? What is secondary hypertension? Okay. So primary hypertension means as a result of the changes that are happening in the body along with old age, you have arteriosclerosis, you end up developing systemic hypertension. Okay, so the problem is in the blood vessels itself. Secondary hypertension means there is some organ dysfunction leading to blood pressure as an add-on with it. Okay, so for example, if my patient has chronic kidney disease or if my patient has any endocrinological disease, for example, if he has pheochromocytoma or if he has thyrotoxicosis, okay, so all these conditions will lead to high blood pressure. If my patient has IHD, secondary to it, he starts developing hypertension because of poor heart function, increased afterload, okay, so all these are my causes of secondary hypertension. So for secondary hypertension, there is an underlying organic cause